Several years ago, it became obvious to me that while we were doing much, much better in our treatments than we had been doing 50 years ago, that they were still inadequate. They were partial improvements. They were out of hospital and living in an adult home, or very few of our severely ill patients were able to go back and lead normal lives, work, marry, raise a family, and do the things that we consider normal, whatever that might mean to you. And there are only two approaches that made any sense to me. One is improved treatment, which is a function of an improved understanding of what's wrong and what can be and should be corrected, can be corrected. And then what made the most sense to me was prophylaxis, prevention. You're not going to see primary prevention. You're not going to see a vaccine against psychosis or a vaccine against depression like you can with diphtheria or polio or the infectious diseases. But then became apparent that one could do something, which is what we call secondary prevention, which is early detection to try to pick up the kids, young people who are going to get sick before they have become really advanced in their illness, and to see if you can intervene early and abort the consequences. Maybe you can't prevent it in a primary sense, but if you catch it early, maybe you'll prevent some of the consequences and some of the chronicity. There are two ways of identifying, for example, depression in an early stage. One is through paper and pencil screening, the kinds of things that one can do, as you well know, or through the internet. And that is helpful in terms of identifying people who are at increased risk. But your problem there is that you have sufficient false negatives or false positives. There are kids who are going to look like they are at risk who will never get sick, and yet you have to say you're at risk, which is not doing them a great favor. And there are people who are at risk that the test misses, and you say, oh, you're fine. So it seemed that if we could begin to get physiologic measures that are associated with depression or schizophrenia or attention deficit disorder or obsessive compulsive disorder, et cetera, et cetera, et cetera, that would be a much more sensitive test than saying you get depressed more than a day a week, or have you ever thought about committing suicide. People that I've worked with over the last 25 years have been working on a variety of imaging techniques to try to identify what the abnormalities are in people who have a particular psychiatric illness. The limitation of that technique is that the patients that we study or have studied, and there are thousands of them, came to us because they were sick. So they were abnormal at the time we tested them. I cannot say to you what that would have looked like a year before they got sick, or 5 years before they got sick, or 20 years before they got sick. Was there always something there which was a warning signal? We don't know. And we're trying to go about looking at, trying to raise the money, to look at the relatives, the younger relatives, children in particular, of people who have been sick, but who are not yet sick, to see if they show any of the same changes or not. Because if they do, then we can say, hey, this is not a marker of illness, it's a marker of predisposition. You're not sick, but you got what it takes. And that would give us a real leg up on how to detect early in the evolution of the disorder who is at risk. And then that person, or if it's a child or family, can say, look, we're just going to keep an eye on the situation. We're not going to do anything. Or maybe we should put this kid and us into some kind of family work to see if we can make our environment at home a little bit more supportive. Or I'm really scared. I think I'd like this child to be on some medication for a while and see if that makes a difference. So that people can make informed decisions depending on their values, depending on their priorities, depending on how seriously they take it, and how they want to go about it. But having information, even if you ignore it, makes me a lot more comfortable than if you don't have the information. And I think we have as a profession, we have a moral obligation to try to develop the information, to make it available, and then people are free to do what they want with it or not with it. Genes are very misunderstood by many people, including many educated people. A gene, or a simple trait, like eye color, is very much what it is. You got the blue-eyed gene, you got blue eyes. But unless you're really fascinated by the color of eyes, it's a rather trivial issue. Complex behaviors such as intelligence, such as judgment, such as attitude, character, let alone mental illness, are not some simple gene expressing itself. Point one. Point two. Genes are turned on and off by the environment. They are activated and deactivated. So the environment is constantly regulating and re-regulating gene expression. Gene A talks to gene B. If one is turned off, the dialogue is different. If both are turned on, the dialogue is one way. If both are turned off, there's no dialogue. If one is turned on, the other is turned off. There may or may not be dialogue, but it won't be the same dialogue. So you're talking about an orchestra. If the violins aren't playing, it sounds one way. When they come in, it sounds a different way. Genes are an orchestra. Culture is far more rigid than the genetic makeup. And yet people look upon genes as a kind of, in a Calvinistic way, that genes determine the outcome. They can, and in some disorders they do. But the more complex the phenomenon, the more steps there are between the genotype and the final behaviors, the more steps, the more room for modulation and manipulation. If we could begin to understand how to regulate what are the environmental events and experiences that regulate, that can be transduced into regulation of the gene expression, then we can talk about primary prevention. Because I can say, okay, now I know how to turn your gene off that's a problem, or it could be a problem. I'm going to get that sucker and keep it quiet. Now, it'll never be quite that simple, obviously. But in order to make it understandable, I'm treating it as if we're looking at single gene phenomena or they're not. But the model is basically correct. If we can understand re-regulation and dysregulation, both not dysregulation, but it's the expression. If we can understand what the environmental experiential factors are that regulate gene expression so that we could control and influence it, we really would be in a catbird seat.